Hi everyone, welcome to Wally's Nursing Videos, your go-to source for mastering nursing concepts. Today we'll be diving into a variety of concepts from perfusion disorders to trauma and immobility. This comprehensive lecture will explore detailed pathophysiology, nursing assessments, critical interventions, medication strategies, and essential protocols like the 1-hour bundle for sepsis. We'll also simplify identifying different types of shock and when to intervene. Let's get started. Module 1, Perfusion Disorders Objectives. 1. Describe the pathophysiology of hyperlipidemia, atherosclerosis, hypertension, PAD, and CAD. 2. Identify connections between these conditions. 3. Plan nursing care and medication interventions to slow disease progression. Pathophysiology process. MAP. Hyperlipidemia leads to cholesterol buildup in arteries, forming plaques that harden and narrow vessels. Atherosclerosis. Atherosclerosis increases systemic vascular resistance, causing hypertension. Hypertension damages arterial walls, further exacerbating atherosclerosis. In peripheral arterial disease, PAD, reduced blood flow to the extremities leads to ischemic ulcers, pain, and necrosis. In coronary artery disease, CAD, narrowed coronary arteries result in myocardial ischemia and can progress to myocardial infarction. Key nursing assessments. 1. Check pulses, capillary refill, and skin color in extremities, PAD. 2. Monitor chest pain characteristics, dyspnea, and fatigue, CAD. 3. Review lipid profiles and blood pressure trends. Medications and interventions. 1. Statins reduce LDL cholesterol. 1. Monitor for muscle pain or rhabdomyolysis. 2. ACE inhibitors lower blood pressure and reduce cardiac workload. 3. Antiplatelet agents, aspirin, prevent clot formation. 4. Educate on lifestyle changes, smoking cessation, low-fat diet, and regular exercise. Takeaway. Understanding the progression of these conditions helps you intervene early, preventing complications like stroke, limb amputation, or heart attack. Module 2, Advanced Cardiac Disorders Objectives. 1. Explain the progression of CAD to MI, CHF, and cardiogenic shock. 2. Identify key diagnostics and medications. 3. Plan acute and chronic nursing care. Pathophysiology process map. In CAD, narrowed arteries reduce oxygen supply to the myocardium, causing ischemia, angina. Prolonged ischemia leads to myocardial infarction, MI, resulting in irreversible muscle necrosis. Post-MI, the heart struggles to pump effectively, leading to congestive heart failure, CHF. Left-sided CHF causes pulmonary congestion, while right-sided CHF results in systemic edema. Severe CHF can progress to cardiogenic shock, characterized by pump failure and systemic hypoperfusion. Key nursing assessments. 1. Assess for chest pain, diaphoresis, and EKG changes, MI. 2. Monitor for crackles, JVD, and edema, CHF. 3. Evaluate urine output, blood pressure, and mental status, shock. Medications and interventions. 1. MONA, morphine, oxygen, nitroglycerin, aspirin for acute MI. 2. Diuretics, reduce fluid overload in CHF. 3. Inotropes, dobutamine, improve cardiac output in cardiogenic shock. 4. Monitor MAP, target 65 mmHg, and central venous pressure, CVP. Takeaway. Early recognition and aggressive treatment of MI can prevent progression to heart failure and shock. Module 3, Gas Exchange Disorders Objectives. 1. Explain the pathophysiology of COPD, pneumothorax, and ARDS. 2. Analyze ABGs and PF ratios to evaluate oxygenation. 3. Plan nursing interventions to optimize gas exchange. Pathophysiology process map. Chronic obstructive pulmonary disease, COPD, results from airway inflammation and alveolar damage, leading to CO2 retention and hypoxia. Pneumothorax occurs when air enters the pleural space, collapsing the lung. Acute respiratory distress syndrome, ARDS, results from widespread alveolar damage, impairing gas exchange and increasing lung stiffness. Key nursing assessments. 1. Monitor respiratory rate, accessory muscle use, and oxygen saturation. 2. Check ABGs. PaCO2 for hypercapnia in COPD and PaO2 for hypoxemia in ARDS. 3. Calculate PF ratio, divide PaO2 by FiO2. 3. A ratio 300 indicates ARDS severity. Medications and interventions. 1. Bronchodilators albuterol, relieve airway obstruction in COPD. 2. Chest tube, re-expand the lung in pneumothorax. 3. Low tidal volume ventilation, protect lungs in ARDS. Takeaway: proper oxygen delivery and ventilatory support can prevent respiratory failure. Be cautious of oxygen toxicity in COPD patients. Module 4. Sepsis and Shock Understanding. Shock pathophysiology. Shock is a life-threatening condition resulting from inadequate tissue perfusion, leading to cellular dysfunction and organ failure. It progresses through 3 stages. 1. Pre-shock, compensated stage. Pathophysiology. The body compensates through tachycardia, increased cardiac output, and peripheral vasoconstriction. On signs: slight hypotension, increased heart rate, and normal urine output. 2. Shock, uncompensated stage. Pathophysiology. Failure of compensatory mechanisms leads to decreased oxygen delivery, metabolic acidosis, and worsening hypotension. As signs: confusion, tachypnea, oliguria, and cool, clammy skin. 3. End organ dysfunction, irreversible stage. Pathophysiology. Prolonged hypoperfusion causes multi-organ failure and cellular death. Signs: coma, anuria, severe hypotension, and unresponsiveness to interventions. Hypovolemic shock causes: 1. Hemorrhage, trauma, GI bleeding. 2. Dehydration, vomiting, diarrhea, burns. 3. Third spacing, ascites, sepsis. Key assessments. 1. Monitor vitals, hypotension, tachycardia, and decreased urine output, 30 ml/hr. 2. Assess skin, pale, cool, and clammy. 3. Evaluate labs, decreased hemoglobin, hematocrit, and elevated lactate, 2 ml/L. Nursing and medical interventions. 1. Fluid resuscitation. Administer isotonic crystalloids, e.g., normal saline or lactated ringers, at 30 ml/K. Monitor response using passive leg raise to assess fluid responsiveness. 2. Blood products. For massive hemorrhage, administer packed red blood cells, platelets, and fresh frozen plasma, FFP. 3. Vasopressors. If MAP remains 65 mmHg after fluid resuscitation, start norepinephrine. Prevention of complications. 1. Monitor for fluid overload, lung crackles, edema. 2. Prevent hypothermia using warm fluids and blankets. Cardiogenic shock causes. 1. Acute myocardial infarction, 40% LV damage. 2. Severe valvular dysfunction, mitral or aortic regurgitation. 3. Cardiomyopathy or ventricular septal rupture. Key assessments. 1. Signs: chest pain, dyspnea, crackles, hypotension, tachycardia, and oliguria. 2. Diagnostics: EKG changes, elevated troponin, and echocardiogram findings. 3. Hemodynamic parameters: low cardiac output and high CVP, 8 mmHg. Nursing and medical interventions. 1. Fluid resuscitation. Administer fluids cautiously to avoid fluid overload. 2. Pressors and inotropes. Norepinephrine to maintain MAP 65 mmHg. Dobutamine enhances contractility and cardiac output. 3. Arterial line placement. Provides continuous blood pressure monitoring. 4. Diuretics. Use furosemide to relieve pulmonary congestion. Prevention of complications. 1. Monitor for arrhythmias using continuous telemetry. 2. Use invasive monitoring, e.g. at arterial lines to guide therapy. Distributive shock, sepsis. Causes. 1. Infections, bacterial, viral, fungal, leading to systemic inflammatory response syndrome, SIRS. Key assessments. Young 1, Q-SOFA score, quick bedside tool for sepsis risk. Altered mental status, systolic BP 22. 2. Muse. Monitors patient deterioration using vitals and clinical observations. Nursing and medical interventions. 1-hour sepsis bundle. Measure lactate. Remeasure if 2 mmol. And obtain blood cultures before antibiotics. Administer broad-spectrum antibiotics within 1 hour. Start fluid resuscitation with 30 ml of crystalloids. Begin vasopressors if MAP 65 mmHg. 2. Passive leg raise. Temporarily increases venous return. Assess hemodynamic response to fluids. 3. Blood products. Administer if hemoglobin 7-GODL to improve oxygen delivery. 4. Pressors. Norepinephrine is first line. Add vasopressin if needed. Prevention of complications. 1. Frequent monitoring for organ dysfunction, e.g. urine output, mental status. 2. Prevent secondary infections with aseptic techniques. Critical calculations. 1. PF ratio. Divide PaO2, arterial oxygen, by FiO2, fraction of inspired oxygen. Example, PaO2 als 80 mmHg, FiO2 at 0.4, 40%. PEF yield 200, indicating moderate ARDS. 2. Cerebral perfusion pressure, CPP. Calculate CPP as MAP, ICP. Example, MAP equals 80 mmHg, ICP equals 15 mmHg, CPP equals 65 mmHg, normal range 60 to 80 mmHg. Role of the multidisciplinary team in shock management. Primary nurse. 1. Conducts frequent assessments, manages fluids, administers medications, and communicates with the team. Charge nurse. 1. Coordinates care and escalates concerns to providers. ICU nurse. 1. Manages critically ill patients, monitors hemodynamics, and titrates vasoactive medications. Respiratory therapist. 1. Manages ventilator settings, monitors oxygenation, and ensures airway patency. Provider, physician, or NP. 1. Diagnoses shock, prescribes treatment plans, and performs invasive procedures, e.g. central line placement. Pharmacist. 1. Ensures appropriate dosing of medications like antibiotics, pressors, and inotropes. Module 5. Immobility and trauma and fractures. Key objectives. 1. Explain the pathophysiology of lower extremity fractures and closed skull fractures. 2. Connect local trauma to systemic complications. 3. Plan nursing care to prevent and manage complications such as intracranial pressure, compartment syndrome, and fat embolism. Pathophysiology process map. Lower extremity fractures. 1. Fracture disrupts bone integrity, leading to localized bleeding and inflammation. 2. Tissue injury causes swelling, which may progress to compartment syndrome if pressure compromises perfusion. 3. Fractures increase the risk of fat embolism syndrome, FES, where fat globules from marrow enter circulation, leading to pulmonary and systemic complications. Closed skull fractures. 1. Trauma to the skull can cause cerebral edema, increasing intracranial pressure, ICP. 2. Elevated ICP reduces cerebral perfusion pressure, CPP, impairing oxygen delivery to brain tissues. 3. Skull fractures can lead to brain contusions or hematomas, further exacerbating pressure and damage. Systemic connections to local trauma. 1. Compartment syndrome. Localized increased pressure impairs blood flow, causing ischemia and systemic metabolic acidosis if untreated. 2. Fat embolism syndrome, FES. Fat globules obstruct pulmonary vessels, causing hypoxemia, tachypnea, and confusion. 3. Deep vein thrombosis, DVT. Immobility post-fracture leads to venous stasis, increasing the risk of clot formation and potential pulmonary embolism, PE. Nursing care plans for trauma complications. Intracranial pressure, ICP. 1. Monitor ICP normal 5 to 15 mmHg using invasive devices. 2. Maintain CPP calculated as MAP, ICP 60 mmHg. 3. Interventions. Elevate head of bed, 30 degrees, administer hyperosmotic agents, mannitol, and control ventilation to maintain CO2 levels. Cerebral edema. 1. Reduce swelling with corticosteroids and fluid management. 2. Avoid hypotonic fluids to prevent further edema. Compartment syndrome. 1. Assess for the 6 Ps: pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia. 2. Prepare for fasciotomy if pressures exceed 30 mmHg. Fat embolism syndrome. 1. Provide oxygen therapy and supportive care. 2. Immobilize fractures to reduce marrow release of fat globules. Deep vein thrombosis, DVT, and pulmonary embolism, PE. 1. Use compression devices and administer anticoagulants like heparin. 2. Monitor for signs of PE, sudden dyspnea, chest pain, and hypoxemia. Traction. 1. Ensure proper alignment and weight application. 2. Monitor for skin breakdown and assess neurovascular status frequently. Pathophysiology of immobility systemic effects. 1. Psychological. Immobility causes depression, anxiety, and social isolation. Prolonged immobility leads to sensory deprivation and cognitive decline. 2. Cardiovascular. Reduced venous return increases the risk of DVT and orthostatic hypotension. 3. Respiratory. Decreased lung expansion increases the risk of atelectasis and pneumonia. 4. Metabolic. Reduced activity lowers basal metabolic rate, causing negative nitrogen balance and hyperglycemia. 5. Gastrointestinal GI. Decreased peristalsis leads to constipation and bowel obstruction. 6. Geniturinary GU. Urinary stasis increases the risk of urinary tract infections, UTIs, and renal calculi. 7. Musculoskeletal M&SE. Disuse causes muscle atrophy, contractures, and bone demineralization, increasing fracture risk. Diagnostic analysis for immobility. 1. Psychological. Use depression scales like PHQ-9. 2. Cardiovascular. Perform duplex ultrasound for DVT. 3. Respiratory. Evaluate chest X-rays for atelectasis or pneumonia. 4. Metabolic. Monitor glucose, albumin, and nitrogen balance. 5. GI. Assess abdominal X-rays for constipation or ileus. 6. GU. Analyze urinalysis for infection. 7. EMSTN. Perform DEXA scans for bone density. Signs and symptoms of immobility by system. 1. Psychological. Symptoms: depression, lethargy, and withdrawal. 2. Cardiovascular. Symptoms: swelling, warmth, and pain in extremities, DVT, dizziness, orthostatic hypotension. 3. Respiratory. Symptoms: diminished breath sounds and productive cough, pneumonia. 4. Metabolic symptoms: weight loss, muscle wasting, and elevated glucose. 5. GI symptoms: hard stools, abdominal distension, and nausea. 6. GU symptoms: dysuria, cloudy urine, and flank pain. 7. MSN symptoms: decreased strength, joint stiffness, and fractures. Therapeutic interventions. 1. Neuromuscular blocking agents, NMBAs. Indications: used in ventilated patients to reduce oxygen demand and prevent movement that increases ICP. Nursing. Monitor train of 4, TOF stimulation for effectiveness, and assess sedation depth to prevent awareness during paralysis. 2. Heparin infusion. Indications: prevents DVT and PE in immobile patients. Nursing. Monitor APTT levels and assess for bleeding. 3. Pain management. Administer opioids for fracture pain, but monitor for respiratory depression. Nursing care to minimize immobility-related problems. 1. Psychological. Encourage communication, provide diversional activities, and consult social work for support. 2. Cardiovascular. Promote early ambulation, use SCDs, and administer anticoagulants as prescribed. 3. Respiratory. Use incentive spirometry and encourage deep breathing exercises. 4. Metabolic. Provide high-protein, high-calorie meals to prevent catabolism. 5. GI. Encourage fiber intake and provide stool softeners as needed. 6. GU. Ensure adequate hydration and provide perineal hygiene to reduce UTI risk. 7. MS. Perform passive range of motion exercises and encourage physical therapy. Conclusion. Thank you for joining today's lecture. We've covered everything from perfusion disorders to sepsis and trauma, highlighting critical assessments, interventions, and protocols. Don't forget to like, comment, and subscribe to Wally's nursing videos for more in-depth nursing content. Until next time, stay inspired and confident in your practice.